Good morning, everybody, and welcome to Health Talk. I am your host, Dr. Niru Prasad, with my background in pediatrics, emergency medicine, and urgent care, affiliated with Henry Ford Health System, St. Joe, Oakland, and Beaumont. The theme of our health talk is some pediatrics issue that is being faced by my guest speaker is Dilan Prasad, and Dylan is a third year medical student at Northwestern. He has a master's degree in science and he is a research associate. And I just cannot catch up with what other things he has accomplished in his life. So I will let Dylan talk about all the accomplishment he has. So good morning, Dylan, and welcome to my show.
Good morning, Dr. Prasad. Thank you for having me. I wanted to start off by congratulating you for winning the AMA Inspire Award.
Oh,
That's a pretty substantial award, and I think it's well deserved and celebrates a lifetime of accomplishments in pediatrics. So
thank you.
I'm sure your viewers would be very happy to know that you've been recognized in this way.
Thank you,
So,
Dylan. Before I get started, please give your instruction to our viewers because you have accomplished so much that it's hard for me even to remember, Dylan.
Sure, sounds good. Well, that's very nice of you to say. Just a little bit about myself. I'm from Chicago, which is where I live currently. I went to the University of Chicago for undergrad, where I studied neuroscience, astrophysics, and chemistry. So, a whole lot of science. And I spent a lot of time after that thinking about how to put all of these things together. So, I did a master's in precision health data science, which is essentially machine learning for healthcare. So after all of this broad interdisciplinary science training, and then some computational training with this master's, I ended up going to medical school, which is where I am currently. I'm a third year medical student at Northwestern. And day to day, I spend a lot of time being a medical student. It's very time consuming, but additionally, we do quite a bit of work with research. So my area of focus is neurology and neurosurgery. We work on brain-computer interfaces and medical devices primarily. So we actually have a group here where we come up with ideas for medical devices. Then we actually build them. We'll 3D print them or we'll manufacture them in-house in partnership with all these different group members. We have engineers, we have legal support, we have experts of every flavor. And then we try to file patents on them and then spin them off into viable ventures. So it's been super, super exciting. I'm very fortunate that in medical school, I was able to find something that I'm super passionate about, which is building these medical devices and trying to solve major clinical problems. And I think that's helped give me some direction for what I want to do down the line and throughout my future practice.
So, Dylan, this is so great. I still remember many years ago when you were entering the college and you were a senior and you advised juniors how to get to the good school system. And I still remember, and now you are a full-fledged research associate and a medical degree. Very proud of you. So you tell me, what are I believe your rotation is in pediatrics these days, right?
Yes, I just wrapped up 6 weeks of pediatrics at Lurie
Okay,
Children's Hospital. So I'd love to talk to you about that, Dr. Prasad, and maybe share some of
sure.
those insights with your viewers.
Sure, no problem. Pediatrics is such an exciting field, and but you picked up neurosurgery, which is way beyond my capacity to know. But anyway, when you go to what was your first experience, Dylan, when you went to the first? Tell us the first day of your pediatrics rotation.
So the pediatrics rotation was at Lurie Children's Hospital here in Chicago. And
Yeah,
Lurie
very
Children's
busy.
Hospital is a very, very, very busy hospital. It's an outstanding hospital, but it's super, super busy. There's people with every type of medical complaint there. And because it's pediatrics, when adults get sick, sometimes it's super manageable, sometimes it's in and out. But when kids get sick, oftentimes it's quite serious. Like if a kid has to come to the hospital and stay in the hospital for a prolonged period of time, it's usually, oftentimes quite serious because kids are really good at healing themselves day to day. But Lurie Children's Hospital was an unbelievable environment in which to do a rotation because you have experts of every kind, like experts from the whole world. Can you see my screen?
Right, that's right. Yes, I see I do see your screen a little bit. Yeah.
Okay, can you see the photo right
This
now?
is the photo of I can see that, Dylan. Thank
Okay,
you
great.
for showing us. Thank you for sharing this.
Yeah, so here on the right side, this really tall building, which is blue with all the blue squares, this
Yeah.
is Lurie Children's Hospital. So it's right here in
Oh,
downtown Chicago, and it's
yeah.
actually right on the lake. If you look at the left side of the image, you
Oh,
can see the
yeah,
lake.
I can see the lake. Yes,
Yeah,
yes.
it's super exciting. So it's a wonderful place to be. And then all of these other buildings surrounding it
Yeah.
are Northwestern Medicine. So
Okay.
Lurie Children's Hospital is affiliated very closely with Northwestern Medicine. Northwestern Medicine is a big health system throughout the Midwest where we have large hospitals, including Northwestern Memorial Hospital, Prentice Women's Hospital, Shirley Ryan Ability Lab, which is a rehab hospital, is also affiliated with us. So right in the heart of downtown Chicago in Streeterville, there's like like 8 blocks of hospital
Oh,
buildings.
yeah.
So at Lurie's, I saw a lot of different exciting conditions and had a great chance to take care of some patients and learn how to manage children in a really, really artful way. So the first condition that I saw for quite a long time was Duchenne's muscular dystrophy. So
Yeah.
Duchenne's is a progressive neuromusculatory disorder. It's a genetic condition, and basically, it's due to genetic mutations in the proteins which are able to give the muscles structure. And it's really a sad and quite devastating condition. So I had the privilege to help take care of a patient who had Duchenne's, a child who had Duchenne's, and the issue with Duchenne's is that there's a lot of different pathologies and there's a lot of different like organ system considerations that pop up with Duchenne. So it's not just that your muscles are weak and you have trouble walking, but your
So
heart is made of
many.
muscle too. And sometimes your heart gets weak and your lungs sometimes get weak too. And it's hard to breathe.
So Dylan, during my, long time ago when I was in pediatrics residency and practice, we did see a lot of this in these patients, muscular dystrophy. But at that time, we did not have all these facilities like you have now. Now you can do so many things with them. We did not. Basically, we examine them, we treat them symptomatic, try to still find out the cause. But now medical science has advanced so much, and I like the curiosity that you have, that you go through the paper, scientific research, and see what can be done to them.
Yeah, exactly. Medical knowledge doubles every
Right.
72 days. That's
Right.
the figure that people cite. I'm not sure what exactly that reference is, like maybe the number of papers that are published, but
Yes,
we
I did
basically
some
live.
research for you only, and
Yeah.
I found I was up till late midnight just looking at those researches that have been done.
Mm. Yeah, there's a lot of research papers that come out. Now, the big issue these days is that not all these research papers actually matter, and not all of them are actually productive in changing clinical management. So, physicians are having a really hard time sorting through the evidence and understanding what papers are really worth reading and what papers are important for changing their day-to-day practice versus
Right.
papers that they can kind of just overlook. So I actually wanted to share something. um, I'm not sure if you can see my screen anymore.
Yeah, I can see the yes, I can see it. Thank you.
Can you
Thanks
see
for
me or can you see the screen?
yeah.
Screen? Okay.
Yes, yes.
So this is a really cool tool that a lot of people in medicine used now, and it's called
Okay.
open evidence. So this is
Okay.
the AI tool. AI is artificial intelligence.
Yeah.
And do you see this black open evidence screen?
Yeah. I see the black and I see a little red circle going through.
Okay, good. So this is a large language model that has been trained on every medical paper that's ever been written. It's kind of
Okay.
exciting. And it's
Okay.
been taught to prioritize papers from reputable sources. So journals like JAMA or NEJM or Nature, those
Yeah.
citations will pop up more frequently. So this is a really, really cool resource because you can just ask it any question and it'll give
Yeah.
you an answer based on the papers and based on the literature and the scientific evidence. So Dr. Prasad, what question, can you think of
Yeah.
any question,
Yeah.
medical question that we can ask this?
So I wanted to ask the medical question. What are the current regime about the treatment of some of this condition?
Which condition? Name any condition.
Okay. How about we start with cystic fibrosis? Because I know you told me you had a patient with cystic fibrosis.
Sure. Let's do what are the current guidelines for cystic fibrosis management in a child, okay?
Right,
Now
right.
watch this.
You know,
So
back,
it's loading
yeah.
and it loads really quickly
Okay,
and then it
yeah.
produces the answer to your question
To the questions, right.
and it
Okay.
gives references. So it's like a research paper.
Yeah.
Look, it gives all of these references here to support
The
the
cystic
text. So
fibrosis.
here, let's see what it says. Current management of cystic fibrosis in a child was a combination of CFTR modulator therapy, which is the receptor, that's the genetic therapy, it's drug therapy, aggressive supportive care, and monitoring for complications. The CF Foundation and Gene Reviews recommend care at a specialized CF center with a multidisciplinary team with quarterly visits for nutrition, lung function, and psychosocial health assessments. Now it tells us about the modulator therapy. So this is first line for kids who have the appropriate CFTR mutations. Usually that's considered the delta 508 deletion. Oh, here it is. F508 deletion. So this is a F, I believe, is phenylalanine. It's a deletion at position 508. So first line is this drug, Trikafta, okay,
Yeah,
um, which is elexacaftor, tezcaftor, and ivacaftor. Then second line is pulmonary management, or not second line, but also is pulmonary management to include airway clearance, so like suctioning for secretions, or maybe like an at-home respiratory support device, mucolytics, and inhaled antibiotics, because that's prophylactic against the infections that cystic fibrosis patients can get, right? And those infections are at a younger age, Staph aureus predominates, and then older, Pseudomonas is the thing that we worry about.
right. Yeah, they get brought to.
So, like, this is unbelievable. Like, this is the answer to
All
a
the,
medical
yeah.
question based
But
on every paper ever written on it, you know?
yeah, but Dylan, I used to see and treat those patients of cystic fibrosis, but those time, not many, there were not many available treatments and not all that. So we treat them and then send them to the specialist. But then I got encountered with a very interesting patient actually started from childhood state, the pulmonary dysplasia, ciliary pulmonary dysplasia.
Oh, wow.
Now this young patient, she was diagnosed as cystic fibrosis and she had a multiple hospital admission, but at the end, with I believe it is a medical, yeah, UFM or where, they diagnosed that the problem is with the cilia. She had the cilia dyskinesia, so her cilia, in the tracheal bronchi passage, whatever food she eats, it goes directly to the lungs because she doesn't have anything in the trachea or the bronchi, to help her. to help her, chew and help her digest. So this way she developed several episodes of pneumonia. Now, for the grace of God and all the treatment, she has become an adult and she can handle herself and she has
Wow.
a good education. So, have you seen more patient in your? Of course, you just started pediatric practice. Ciliary dyskinesia, which has been diagnosed as cystic fibrosis before, but it is not cystic fibrosis. The problem lies in the cilia of the tracheal mucosa.
Yeah, so this is a very interesting story, Dr. Prasad, and this is a evolving medical knowledge point here, right? Because this is the sort of thing where case reports would have been needed in the 70s, 80s, and 90s to
Yeah,
properly differentiate between the conditions. So now I believe they call this condition primary ciliary dyskinesia.
a primary ciliary
Yeah, I think
dyskinesia.
they've
Yeah,
renamed it over time, but it's due
yeah,
to a mutation in the actual proteins that consist of the cilia and the flagella. So these
right.
tiny little motile fibers, and it's super interesting because, well, certainly you have all these issues with recurrent sinopulmonary infections due to poor clearance, but
Mhm.
you can have these other very bizarre, like perplexing complications, and one of them is called Cartagener's syndrome, which is also known as
Yeah, I heard.
Swing's
Yeah, I read about that syndrome. Tell
yeah.
us about it.
So this is when the heart is on the wrong side of the
Right,
body.
yeah.
Um,
Dextrocardia.
Dextrocardia, yeah, and then also in men, this condition leads to infertility because
Yeah,
the semen, the sperm are, and the semen are unable to swim without the use of proper flagella. So it's
yeah,
very fascinating. I've never seen this condition myself, but I've heard a lot about it.
yeah. It has been reported so many times. So now we talks about the lung issues, muscular dystrophy. What is the other interesting patient or other interesting title you want to talk about that you saw in the pediatrics rotation?
So something that I saw a lot of was meningitis.
Yeah,
Meningitis is very uh, concerning and potentially devastating. So, meningitis is an infection of the meninges or an infection of the central nervous system. It's actually quite common in neonates and very young children due to immature immune systems. So, like a major risk factor for meningitis is complications during birth. So, like chorioamnionitis, which I believe they now call IAI or intrauterine infection. Um, this is something that is known to pretty often cause meningitis. And now in the hospital, we give, based on like a neonatal sepsis score, we give prophylactic antibiotics so that babies who are at higher risk of developing an infection, um, hopefully, will receive like ampicillin and gentamicin and sometimes other antibiotics to minimize that risk. So they'll receive that prophylactically. So this is the type of thing that's actually in the modern era been almost solved relative to how it used to be in the old days, right? Where
yeah.
a lot of people were getting meningitis and having serious
I,
complications.
I tell you, Dylan, I used to see so many of this meningitis, mostly H flu meningitis, and then you do the spinal tap, and I remember one kid, infant, full of pus. That was meningococcal. Another one was H flu. But now, thanks to all the vaccines that we have it on board, these cases, the HIV vaccines and all that, they have prevented the episodes of meningitis in children or the newborn. Do you agree with me?
Yeah, I totally agree. Regardless of how people feel on vaccines, like some of the things are kind of undeniable. When we see a patient in the outpatient pediatric setting, for example, let's say a 5-year-old boy who
Yeah,
comes in with a serious infection, if the child is not vaccinated at all, then the differential for what is causing the infection is much larger.
right.
There's a lot more things that are possible. So the vaccines have certainly helped with reducing a lot of the serious burden of infectious disease.
Yeah, and there have been so many researches done in the vaccines through, the immunizations and all this, and I went through those. And then the COVID, can we just talk about a little bit about this COVID that dropped on us 5 years ago, Dylan, and it is still lingering.
Yeah, the COVID, we actually didn't see all that much of it in the hospital. Next, I'm going to be talking about my time in the pediatric emergency department. I spent quite some time there, and I would love to hear
Yeah,
your take on this, Dr. Prasad.
Omicron.
But in the winter time, I believe, is when you usually see the most like COVID kids coming in, or like the RSV bronchiolitis
Yeah.
exacerbations and all of those things, croup. So we saw some of it in the ED, but not all that much.
Yeah, so the vaccines, definitely different kind of vaccines, with all those new modalities, the vaccines are helping the children, whichever age group they are in, right? To
Right.
some extent, right?
Right. Yeah, to some extent, for sure.
Okay. Now, would we like to talk about some of the injuries, that children develop while they are playing outside sports injury, and did you see those, some of them at least, with the immediate or the post traumatic episodes?
I did. Yeah, I saw actually quite a few MSK injuries in the emergency department. A lot of kids, if they like bonk their head super hard or they're bleeding,
Yeah,
their parents will bring them in for concussion evaluations just to make sure things are uncomplicated. So
concussions.
we had one kid come in who had like a laceration on their nose. So he came in and we just washed it out and sent him on his way because he had no red flag signs of concussion. We had another kid come in with wrist pain after falling off some monkey bars, and turns out he had a distal radius fracture. I think it was Salter Harris type 2 or class 2 fracture. The protocol in the Lurie ED is if there's MSK injuries to just get like rapid X-rays, and they're really really good about having X-ray there and done and read within like 10 minutes. So it's super impressive to see actually. Like if you come in with a potential fracture, then you can get a diagnosis very quickly, and you can get a sling and a cast, and then sent on your merry way. So.
Yeah, but Dylan, I still remember, a pediatrics office practice. I did a sports physical for a 12-year-old guy. Everything was okay. He started playing football. The same night, I was moonlighting at emergency room, and this triage is calling me. This kid was hit on his head, and he was unconscious. Thank God that neurosurgery was online. We did the CT scan, and they removed a big hematomas from his
Wow.
skull. Yeah. So those are the things, that are the red flags of medicine. You agree with me, right?
Yeah, yeah, I think so. Like, this is why it's so important to have a well-staffed children's hospital with
That
experts from
is
every
true,
service,
right?
because anything can happen in kids. Like,
Yeah.
it's crazy how many things can happen. Like, it's just so
Mhm.
broad, and you really don't want to miss anything. So it's great to have those experts there and multiple layers of eyes on a patient to really triage complaints well.
Triage.
Honestly, I think this is a big advantage of the academic setting. Um, a teaching hospital is good for this reason, because you can have multiple eyes on the same patient. You can have multiple people asking the patient the same questions. Like the students, then the residents, then the attendings will oftentimes overlap a little bit in what they're asking. And then there's consult services. Like, for example, some of our more complex patients who are inpatient at Lurie Children's Hospital for a long time, we had like
Mhm.
6 different teams consulted to
Oh,
manage, and each of these teams are taking their own histories and writing their own notes. So
right.
I
Yeah.
think overall, it just really elevates the quality of care.
Yeah, you were right, because I watch games for my grandchildren playing football, baseballs, and hockey. And then if the kids fall down, they are being triaged by the paramedics. Okay, of course, if they are able to walk home, they go home. If they have a serious issue, they go to the hospital. But those ones, Dylan, they go home and then later on they develop symptoms of headache, insomnia, and there's a post-traumatic issue that is going on. Do you have any comments on those? The post-traumatic,
Yeah. So, are we talking about in the short
this,
term or in the long term?
yeah.
So,
So,
in the short term, like you can definitely have a concussion, right? So you
yeah,
go home and then you have delayed type
the
symptoms.
minimum concussion, yeah, yeah.
Yeah, concussion.
Yeah, with the concussion, and then they develop headache loss of memory. They don't want to go back to school. So those are the patients that are referred to the neuropsychiatric department, Dylan.
Right, right. So the usually the red flag patients who have red flag symptoms like focal neurological deficits,
Yeah, for the
that those are the patients who are going to be good candidates for imaging, so like CT, MRI, and then potential referred to neurosurgery. That's like God, like hopefully that doesn't happen, right? Because
right,
it means
yeah, yeah,
there's something wrong.
yeah,
But most concussions are kind of non-specific symptoms of like dizziness and nausea, like headache, sometimes
yeah.
vomiting. A big common complaint is like nausea with reading, which is one of the reasons why um, you're recommended to not look at screens and not like read or do anything too taxing for a while.
Yeah. So depending upon the trauma, I did all the Google search and everything, mild, moderate. The mild are the ones where they are being sent for the cognitive behavior therapy, right? Of course, the serious ones, are immediately taken care of for those
Right,
kind of kids.
right, yeah.
So anyway, so anything else you saw interesting during your pediatric rotation that we can talk about, Dylan?
Yeah, I saw this really exciting, really interesting case. Not exciting, but interesting. So, ear infections, right?
Oh
Otitis,
yeah, right.
otitis media.
That should be the
Um,
first one we should have talked about in video. How can we miss that? Okay, go ahead.
So
Then I'll tell you my
otitis
story.
media is very common complaint, bread and butter pediatrics. It's
Right.
just like an ear infection of the middle ear. In many cases, you don't have to treat it; it'll self-resolve. But in some cases, like if there's a super high fever that persists, or if there's significant ear pain, or if it's like complicated with effusions and things like that, then you usually want to treat it with antibiotics. The most common bugs that cause this are strep pneumo, H flu, and MCAD, and then you would treat it with. You usually start with a high dose amoxicillin, so 90 mg per kg BID divided, and then if there's an issue there, and you have to kind of escalate things, you might give augmentin. But
Right.
the feared complication of otitis media is actually having the infection disseminate to other places, to kind of like travel.
Exactly.
And one common place for it to travel to is the mastoid, which is this whole bony process right next to the middle ear. And that can lead to mastoiditis, which is a big inflammation of the ear. So it's the bone right behind the ear, actually. And
Yeah.
sometimes you'll see kids with mastoiditis, their ears will be like sticking out a little bit because of the inflammation. And if you press on the edge of their ear, they'll be in a lot of pain. But if mastoiditis goes untreated, you can have further dissemination of the ear infection, and theoretically, it could get so bad that it could become meningitis or it could become a brain abscess. And that's actually one case that we saw at
You
Lurie's.
did see a case like that, Dylan?
We did,
Okay.
yeah. We had
Yeah.
otitis media became
Hmm.
mastoiditis, became
Yeah.
meningitis and abscess. So that was very interesting. The kid just didn't have medical care, and it must have been like a resistant bacteria. I don't remember exactly what bacteria it
Hmm.
was, but We started antibiotics and everything was fine. But yeah, I thought that was a very, very interesting case because it's just not something that you see too often.
Yeah, but Dylan, the bread and butter of pediatrics is treating sore throat, tonsillitis, and otitis media. Amoxicillin is the is the choice of antibiotic we use most of the time. And I do remember working at emergency room. Triage is calling me. The kid is 9 months old and he's crying, crying, and crying. Nobody knows what is wrong with him. Finally, when we quietened him down, checked to the ear, and he is at acute otitis media, the ear X. That is, so that is what bothered the kid. So it all age, especially in the young age group, we used to see a lot. But now things have improved. The parents and the caretakers are more educated now and they know exactly what to do. If it is a cold, running nose, then you give them some decongestant to soothe them. If you don't, then it spreads to ear infection, like you mentioned before.
Yeah. Yeah. It's exciting to see what's changed over the years and kind of like what stayed the same.
That is true, yeah, yeah. So that is very nice. We covered some of the good topics and the red flags of pediatrics with you, Dylan. So, do you have a 1 minute keynote advice for our listeners who are watching our webinar?
Well, I would start off by saying anyone who's going into medicine, please strongly consider pediatrics.
Okay,
Pediatric inpatient medicine is just adult medicine, but more fun because kids are adorable, and the conditions that they have are oftentimes more exciting. It's like you don't really see as much like bread and butter adult medicine. You don't really see as much like heart failure and the fluid
right, yeah.
problems, hypernatremia. You see a lot more mastoiditis or
That is
asthma, and sometimes like more advanced neuromuscular diseases. You see a lot of undifferentiated neurological complaints, which is pretty
exactly,
interesting.
exactly.
So that would be one point of advice. And then the second point of advice for people not going into medicine is just please see your pediatrician at the appropriate frequency in the outpatient setting. So make sure you're going in for your well child visit every year. Please try to vaccinate your children, and then also make sure that every time your children get sick, you call your pediatrician as soon as you can and take them in because you
So
never know what your
yeah,
pediatrician's going to catch. So.
these are very good advices for Dylan Prasad, who did his rotation at the Children's Hospital. And apparently, he wants to become a neurosurgeon, right? So that's good. I, Dylan, I wish you the best of luck with whatever you are going to do. And we are very proud of you, a medical student with all these degrees and what is ahead in future for you. I like to thank our viewers for watching me on the podcast with Dylan Prasad, third year medical student and master's degree in bioscience. And I'd like to thank our producer at Bloomfield TV for letting me record this wonderful podcast. Thank you again.